Hello, everybody. I'm Brian, and we're here at AMI Exchange 2023 in beautiful Long Beach, California. This is day 2, and we're at pretty much the tail end of the Expo Hall day here. And I'm with Eric today to talk about a session that a lot of people were a little bit of a buzz about. I heard this buzzword, extended reality. Eric, can you introduce who you are and tell me a little bit about that?
Sure. My name is Eric Ehring. I'm an asset administrator at Mayo Clinic, which is a little bit different title. I'm kind of a manager essentially over a team that supports our medical equipment systems. So any equipment that is networked medical systems, primarily telemedicine, virtual care equipment, but we also support a few other, some pharmacy equipment, even some equipment that this patient monitoring. Anything that's heavily networked usually comes to my team.
Including, I'm guessing, VR goggles, things of that nature.
Including VR, XR, the XR goggles. And you say, XR, extended reality, which kind of encompasses virtual reality, augmented reality, and mixed reality devices, depending on their technology.
Can you tell me the difference between those three that you just mentioned?
Sure. So, looking at the reality we live in currently, kind of coming over to augmented reality, where you're looking at our current reality, but you're kind of dropping in a visual item, a visual cue, where there just be an arrow to look at something or someone circling something on your screen.
Maybe I take my phone and Pokemon Go. I think
Pokemon Go is a great
example
of augmented reality. It's actually kind of starts getting into the mixed reality when you have Pokemon moving on your screen. It can be moving across your screen. There's some companies that have actually been able to kind of import the spatial layout around you and turn that into a digital image, and then even place virtual objects onto those images, which is
that's amazing.
Pretty crazy if you think about how you could even lose touch with reality doing something like that. And then we have full virtual reality, which is 360 degrees of just, digital creation, essentially. Nothing is real.
I'm going to be putting on a VR headset and losing my sense of balance.
Yeah. Ready Player One, it's a really common movie reference, and it's such a great example of what, virtual reality could be in our dreams, I guess.
Yeah. So I mentioned, people were a little bit abuzz about your talk. So I wanted to know a little bit more about what that session was about.
Yeah, that session is essentially, we at Mayo Clinic decided that HTM was going to assist with the onboarding and management process of VR and AR goggles because there was a need. Yeah. And it kind of made me think we asked ourselves a lot of times, especially in my group, is this HTM? Should this be IT? Should this be facilities? And, that's a really difficult question with VR goggles because they are in the OR. They are in patient care areas. They impact patient care. We're using them for patient care. But are they really medical equipment? And the reality is, if your facility wants to bring in a lot of different make models of equipment, HTM is really the best place to do that because, we're struggling to bring in 100, we have, I think, 30,000 different make and models of equipment, in HTM versus you look at IT, it's probably less than 1,000.
Right.
We've definitely perfected the process of onboarding equipment that doesn't fit our
familiarity
mold.
With compatibility, that kind of stuff.
Yeah. And identifying risks and reporting those risks accurately, getting through the security process. We have our own security team in HTM that's more familiar with that type of process. That's kind of how it landed with us. And, we still ask that question, are we the appropriate, place for that equipment? Just because we want to be successful, we don't want to be an impact to the practice.
Well, we can't convey the whole session, of course, but any pro tips that you would want to leave with our viewers right now?
Pro tips. The onboarding process for VR is really complicated right now because it's just changing so rapidly. It's an industry that's far beyond healthcare. So MDM, which is our mobile device management, is very difficult with VR currently.
Sure.
So trying to forward think a little bit and guide the practice has been our goal right now, because if we can create an MDM solution or at least get an MDM solution that works for a majority of them, we really, really mitigate our risk. We make the onboarding much easier, and that's becoming a reality in the industry. So we've been able to do that with some, still working on others, but mitigating that risk.
No, that's a big call to action we kind of hear among almost a lot of these subjects when we talk about disruptive technologies is future-proofing for HTM departments, acquisition, things like that. But you were telling me that this is just one hat, of course. You mentioned your main focus is almost telemedicine. You want to tell me more about that? As we know personally at AMI, that telemedicine is kind of become a big subject of discussion post-COVID, right?
Yeah, so that's our virtual care wing, or essentially all of our technicians we have enterprise-wide. We're really hired for telemedicine. So we have a Center for Digital Health group within Mayo Clinic that offers these products out to the practice. So we have telemedicine from emergency departments for ambulances for strokes and codes, and NICUs for urgent premature babies that may be born to basically extend the Rochester care network, our Rochester being our hub with as many providers as we have, specialty providers, all the way to we have, I think, about 900 or so devices that are kind of distributed for virtual nursing and virtual monitoring, kind of our inpatient practice, as well as even devices in the outpatient clinics that help us extend our network as well.
One of the things we've noticed is that, there was a big wave in telemedicine acceptance and adoption because of COVID, of course. But then there was somewhat of a scale back. After, we saw in the VA, for instance, that adoption kind of scaled back after COVID. Is it because people want that in-person view? Are you seeing the same thing on your end?
So I can explain that pretty quickly, actually. During COVID, and I basically started my position in April 2020, so it's a great time to start a new position. During COVID, we saw this immediate need. We need isolation. So we need to get the device in the room. We'll keep the doctors out of the room. We'll have isolation, and we need to preserve our PPE. That almost immediately shifted. Within about 6 months, that came, we don't have enough staff for all of the patients. We need to get an ability to have less staff.
Yeah.
And that's how virtual nursing really took off. Virtual monitoring really took off. And it essentially would required us to have one device per bedside in any of those units that were getting that support. Fast forward a year or two when we've been able to allocate some budget and we've been able to replace those kind of quick haphazard devices that we were slapping out. Like we call them tablets on sticks, which is basically a tablet on a roll stand with a more, dedicated hardware that's designed to be in the patient room. And that's really what we've been doing for the last, 2.5 years. We've been doing that to get a more robust hardware solution that's a much, much better experience for the providers.
That's excellent. And I'm curious then if you're seeing, major trends that you're expecting, not just Mayo Clinic, but anybody who's thinking about cybersecurity, telemedicine on that side of that.
Well, from a cybersecurity perspective, I think it's pretty much continuing to be the same, but telemedicine, we're seeing ultimately a shift in the integrated room. So, we look at the patient's room, the integrated room with nurse call and, the devices and the patient monitors kind of integrating. I feel like telemedicine is becoming a standard solution there.
Okay.
Every room essentially is getting a camera, from what I can tell, when we do a new construction project, because we had that experience with COVID where we wanted a camera in the room, we didn't have one. And now we're going to put one in there, maybe if we're not yet going to use it, we'll plan for the infrastructure for one, because the infrastructure is such a barrier if you don't have it in during construction.
And it's fascinating too, because, you're on the HTM side of things, and we're talking about the implementation of these devices that, both VR headsets and maybe even telemedicine, tablets on a stick, that may not necessarily seem like, the medical devices that you would see repaired in an HTM department. Are you expecting more devices like that to wind up becoming out of the gray area and moving into the HTM department?
Yeah, it's going to very, very much depend on the hospital that you're at.
Yeah.
I was very fortunate to be placed in the position I am. I was able to apply a lot of clinical engineering practices of actually reviewing equipment before the providers got a hold of it, which was pretty incredible for HTM. So we were actually able to review equipment coming from the vendor, check that it's loud enough, check that it's giving good alarms, check that it's, the casters are big enough to get through an elevator threshold, check that it's got a tip test. I've actually used the AAMI standards for heat dissipation to reject vendor products. So, that's stuff that typically would not go through an IT process, that's for sure. Not saying that, other people couldn't catch that, but I think HTM ended up being a very, very good place for us for telemedicine, bringing in products.
What about collaboration? You mentioned IT, so there's a health IT department. Do you ever work with them?
So we're in our IT. We and HTM are under the IT umbrella at Mayo Clinic. I work with my IT colleagues very closely every day. We speak about MDM. We have a very great MDM team that we work with to secure the products that we can.
Yeah.
We work with them for a roadmap for the products that we can't. Speaking of VR goggles, that's usually our conversation is the roadmap for how we're going to do that. But yeah, we work closely with IT. Typically when we do our systems like telemedicine, because there's so many server level applications and, connections between vendor clouds, we act as more of a level 2 support team, and they have a level 3 support team on the application side, which is a little bit different structure probably for most HTM departments.
Well, it's maybe something that some of them can start thinking about then if it seems effective to them. But before we wrap this up, I did want to ask you if there were any major takeaways that you would think, attendees at AAMI Exchange, if there was one thing that they would get from this interview, what would you want them to know about?
Ooh, one thing. I mean,
Hey, it can be more than that.
What I love about coming to AMI I come here almost every year, and what I love is that it's kind of the same, but there's just these little things that are different you can kind of see as an industry shift. And I see the VR becoming a part of HTM as well, not just our industry, but HTM training. We got Invert over here doing VR training.
Right.
This College of Biomedical Equipment Technology, who was well positioned for COVID to do the online training. We need to be forward thinking as well as how we're going to do training in the future. And I know a lot of people got training budgets cut and travel budgets cut. It's hard to get budgets back after they're gone. So you just be forward thinking. We have to think, more than 2 years ahead on our budget and how we're going to do things.
All right. Be forward thinking. That sounds like a great takeaway here. I do appreciate you taking the time to sit down and talk with us right at the end of this conference. And please enjoy the rest of it.
Thank you very much.
Been great.
Thanks for having me.